Thank you, Jerry. And just that we're slightly ahead of schedule. I'm going to maybe move up one of the sessions from the afternoon and keep on the theme of, I suppose, the areas that are outside of ABF at present. So ED is one, the other is outpatients. So I'm going to ask our senior statistician, Lorna Collins, to present on the work to date in relation to the outpatients. So this is actually an afternoon presentation that we're just moving forward, given that we're ahead. Okay, so I'll just hand you over to Lorna.
Thank you. I'll be very quick so that you can get to have your... Oh, yeah, Brian's very tall, sorry. We're back to the short people again. Is the outpatient? Yeah, great. Can we go back a few? Okay, I'll be very, very quick. So outpatients in ABF is a key component of both the ABF implementation plan and of Sláinte Care. It's actually detailed in the Sláinte Care under 7.1.3, which is to examine the use of ABF for outpatients in the ABF environment. The HPO is at the moment seeking to establish an outpatient ABF funding working group to provide strategic guidance and subject matter expertise in the outpatient setting for the likes of service provision, data collection, clinic classification, costing, pricing, and funding approaches. Outpatients. So currently there's about 3.5 million outpatients. If you think that's double what we're getting in our HYPE data of 1.7 million at present. 1 million are new and the balance is review. About a half of those are failure to attend, so DNAs. On average, we have about costs €180 for an outpatient attendance, and that we get that from our specialty costing data. Currently, we have very little information on these patients. We do get very top-level information from our colleagues in the BIU who provide that information to help us do the €180, but we don't have the level of granularity that we would have for our HYPE data, for our inpatients, for our day cases to do ABF. Each hospital also defines their directorates, and therefore the information we have isn't really comparable across the system for outpatients. So really we need to know the who, the what, the when, the where, and the why. What I mean by that is, who are we treating? What are the demographics? Where do they live? Where are they coming? What are our age cohort? What are they coming from? Is it a medical procedure? Is it diagnostics? Is it allied health? When are they coming? What time of day is the most busiest time? What is the day, the month, the year? Are they new return? Is it urgency? Where in the hospital? More and more we're seeing that outpatients doesn't just sit in an outpatient area. It can be in procedural suites, it can be in diagnostics, it could be in a day ward, it could be in a hospital ward. So we need to know exactly where that activity is happening if you're going to cost and fund that activity. Why are they there? What's the purpose? What's the clinic? What's the specialty? What's the consultant? Is it a joint clinic? Is it a multiple disciplinary clinic? This is all the information we need to capture if you're actually going to fund the activity that you want through ABF. So how do you classify 3.5 million attendances? So as with most things in the HPO, we have talked to our colleagues in Australia who have been very kind and very generous in giving us information in terms of their Tier 2 outpatient clinic definitions. And this was decided as being the best way of developing classification for an outpatient clinic in Ireland. We are using it as our version of outpatient classification, so our Irish variant. So we have used it, but we've modified it for our system. So it's going to be called the Irish Outpatient Classification System, and like the DRGs in inpatients and the URGs that Jerry spoke of, we're going to call them outpatient clinic groups. So it's OCGs. The reasons we adopted it is that the structural hierarchy is based on both the provider and the activity, so that every hospital clinic has a place in the definition. The number of categories and the descriptions were developed to ensure a sufficient coverage of hospital outpatient activity, and the exclusivity across the clinic category means that there is a clear choice of hospital clinic. It was developed for the purpose of reporting and funding hospital operational clinics. The clinics were grouped in a structure reflected and underpinning the logic in the cases of DRGs. So we have that complies with the logic we're using in our current system of classification for inpatients and day cases. Also, it's the most feasible option for development of a classification with a reasonable short time. So in terms of how does the Tier 2 compare to what we have for our Irish classification? In the original Tier 2 that we first looked at, there was 107 classes identified. In the first version of the IOCS, which Jacob Johnson and Dr. Andy were involved in creating, we had 106. Where the original version was appropriate for the Irish system, we kept it. Where it wasn't appropriate, it was amended and modified so that it could be used for the Irish system. In April 2020, IPA released the latest version 5 and then a version 6 soon afterwards for COVID. So I did a complete remapping of the classification to take into account the latest kind of clinics that are in Australia, latest kind of clinics that are in Ireland. Part of that was to future-proof outpatients for coming years and how treatment in outpatients should be shifting left to community, but also home-based procedures that may work out of your outpatient area. There's also 3 additional clinics to take into account of COVID-19. They're medical, consultation, diagnostic, and allied health. So it's more to just future-proof it going forward. So there's 141 at present that we have OCGs. It's anticipated that the OCG will be more effective in reflecting equal payment for equal output regardless of the service location. There's 4 classes of care in outpatients, and underneath that you've got your subclass, which is your OCG. So it's based on codes. So the 10,000 codes are procedure clinics, the likes of minor surgical, dental, endoscopy. You've your 20,000 codes, which are medical consultation clinics, so hematology, pain management, general surgery, respiratory, diabetes. You've got your 30,000, which are standalone diagnostics, which are general imaging, MRI, pathology, clinical measurement. Allied health is the 40,000, that's clinical, nurse specialists, and nurse practitioners as well. So that's your OC health, your wound management, respiratory medicine support, and clinical and cardiac rehab. For every one of the 141 OCGs, there is a data element and definition for every single one of them. So if we take minor surgery, which was one of the first we mentioned, you have the number, the name minor surgical, the procedures that happens in it. It's multi-MDC, which is a major diagnostic category, similar to what you have for your DRGs. And then it's the usual provider, in this instance is a surgeon, general surgery, or anaesthetist. The definition of the service is the conduct of minor surgical procedures that do not require the patient to be admitted to hospital. These may require the use of specialised procedural suites and or anesthesia services. We give a guide for use, so your inclusions of biopsies, excision of lesion, literacy, pleural tap cryotherapy, and then we give you exclusions. So it doesn't include dental procedures because that has its own OCG. It doesn't include minor medical procedures because it has its OCG. So the exclusions and exclusions help to clarify what's the appropriate clinic for the kind of information you're looking at. An example of a medical one is general medicine. So that's 20,050. It's general medicine, it's medical consultation, again, multiple MDCs, but the specialist decision is a general medicine. The assessment, the definition of that service is the assessment, management, diagnosis, and or research of medical conditions where the patients are not required to attend a specialist medical consultation clinic or such clinics do not exist. Again, the inclusion is general medical conditions, but we have exclusions for geriatric medicine and paediatric medicine because they have their own OCG. So the process of mapping your outpatient clinic to the OCG is based on the definition of service, the specific rule set, and the criteria of assignment to the OCG. You look at your clinic category. Is it procedural medical, a standalone diagnostic, or allied health? Is it MDC? What's the provider of the service? Your definition of the service is the main driver of the OCG assignment. Your inclusions and exclusions really give you your clarity and crystallise where your OCG actually has to go. To support and to assist this kind of mapping process, we have been developing an online outpatient clinic register. Joe Hunter, one of our software developers, was key in developing this piece of software. It is a web-based application, so you don't need any additional software to have this in your hospital. It is part of the HPO's web applications that we have. The reason for collecting this information is that you need it for mapping your outpatient clinic to your OCG, but it's also resource information that we need in terms of activity-based funding. So you have your clinic description, your classification, and your clinic timetable. So your clinic description is what is your clinic, what's the PAS clinic code, or your IPIMS clinic code, what's the location of it, what's the delivery service of it. Your classification is what's your consultant, your specialty, is it procedure, medical, diagnostic, or allied health, what's your OCG, and clinical governance, is it nurse-led or consultant-led. Your clinic timetable really gives us the resource of the clinic in terms of ABF. So what's the frequency of it within a month? What's the days, specific days of the week? What's the start times, end times? And is it an on-demand clinic that only happens whenever a particular situation arises? I'm not going to do a live demonstration of this just for time purposes, but if anybody wanted to go through it and see it, then send me an email and I'll happily take time to go through it with people. This is that online web application. We're basically collecting the information that I've just spoke about. It's mostly drop-down. It's very few free text fields. If you can book your holidays, you can use this website. There's no more difficulty than that. So we're selecting your hospital, you're selecting your PAS or your IPIMS clinic code, and then a clinic description. And I've noticed a lot of the clinic descriptions we see are, say, Dr. Deirdre Murphy's clinic. That tells me nothing about the clinic except that it's Deirdre Murphy and she's a doctor and she has a clinic. So we need to have a description of what actually happens in the clinic. Is it a respiratory clinic? Is it a diabetes clinic? Is it a dental procedural clinic? The next thing is the clinic timetable. So is it the first Monday of the month between 9 and 12? Is it Monday, Wednesday, Friday on the second week of the month? There is every single option of selection of date and time and frequency in that table, and you can also select your on-demand. The next is your clinic specialty and your consultant. Then you're selecting whether it's procedure, medical and other, or your allied health. And then you're putting in your OCG. And we ask the hospitals to select their OCG because you know your service better than anybody else. But we do ask for a reason for the assignment because we will work with you in terms of clarifying and crystallising that information. And maybe there might be a better OCG that we feel appropriate for that information. So between the clinic description and the reason for selecting the OCG, we're going to support you in the process of doing that. And then it's just information in terms of your clinic governance, clinic mode, and whether it's public or private. And that information is then saved in our database. So it's there, it's live, you can access it, and you can put all your information into it. The information that's being collected is huge. It's a massive amount of information. It can be so useful and so valuable in terms of an outpatient management system. So I've built a very quick dashboard. I apologise, it's very rough and ready. I just did it for the presentation. I just hooked into the SQL database and I just built a Power BI dashboard off it. But to give you an indication, if you're putting all this information into this tool for us, what you could get back out of it. So we've used UL as part of our pilot project, and I'll speak about that in a minute. But this is draft data at a point in time. But as you can see, you can select your hospitals, your clinic mode, your clinic governance, where the location of the activity is happening, what's the OCG of it. You have your table in the middle of it, which will dynamically update based on your selections, but you can also drill down into the selections of the table. At that point in time in that pilot project, there was 572 clinics allocated across the whole UL group. 2 had no OCG because they were in the process of being categorised. We can see that vast majority are medical, there's 355. There's 192 allied health, 13 diagnostic and 10 procedural. But you can drill in and pick whichever you want. Something that became huge in the pandemic was telemedicine and moving outpatient appointments to telemedicine. If we select telemedicine from your location, straight away you can see there was 18 clinics in total. There was 5 medical, 13 allied. They were across 5 of the hospitals in the group. And you can see that in terms of the medical, they fell across 4 OCGs, so general surgery, respiratory, vascular, and breast. If you put your time information into that and your scheduling, this becomes a massive tool in terms of your outpatient management, in terms of scheduling of clinics, in terms of your staffing resources. Where are my doctors and what date and what time? Where are they? What's happening and what's happening in the clinics? So in terms of you providing information in terms of your clinics for outpatients, you're going to get a lot back too in terms of being able to see what exactly is happening, when and where. So we did a pilot in the UL Hospital Group starting in 2019, and we met with the UL team. They were selected as the group for the pilot because all of the hospitals in UL were on the same version of IPIMS at that time. So the HPO being, at the time, Fikra, Brian Donovan and myself went down to UL and we met with the outpatient manager, Julia Cotter, the group data analyst Audrey Allen, and the clinic request manager Jennifer McCarthy, in conjunction with Dr. Andy, who basically helped us to go through what we were trying to do in terms of the pilot, trying to form the process of why we were trying to capture all this clinic information, and then trying to map those clinics to the appropriate outpatient clinic group. The UL outpatient team really undertook this process. They were fantastic. Myself and Anne went down for another day and went through an example of how to map all the clinics, what the process to undertake, how to do it, and they mapped every single clinic in every hospital in the UL group to an OCG. We got really great learnings from the outpatient manager, Julia Cotter. She was giving us back benefits and learnings, things that were important to us. And at that time, the feedback we were getting from them helped us to develop the outpatient clinic register. Every time that something was coming, something was difficult, particularly the clinic timetable, I had no idea clinics happened in so many different ways, but we were able to capture all that information. We were also able to get some outpatient patient level data and from Audrey Allen, and we were able to start reviewing that data, putting quality assurance and quality measures in place in terms of that, and we were starting to feed and return back that. We also started to work with the IPIMS team in terms of adding the OCG to your outpatient clinic setup window, so that when your outpatient clinic was being set up, you have your PAS clinic code, your outpatient clinic code, and then your OCG sits on the record. So once it's put on there, it sits on there, it's there forevermore, and it doesn't have to change unless the clinic actually changes. And everything was going wonderful, and on the second week of March in 2020, we were about to have a big meeting and everything was kicking off and we were moving forward. And then UL rang and said they had to close everything and they were cancelling all their outpatient appointments, and very sorry, we'll talk to you when we can. So COVID delayed everything at that point. We did take on board the benefits and the learnings that Julia Cotter had given to us. Some of the things that really came out of it was that Julia felt that this would really facilitate real-time capture of your information outpatients, that you'd be able to see changes in clinics, updates in clinics, and that if an audit had to be done in your outpatients, that this could be your source data for pulling from the system to use as your outpatient audit. The learnings was that governance, protocols, national protocols, making sure that they were all in place to support the process. Challenges was that it's the standardisation of that process, that there was many people involved, they were all doing the same thing. There was also a large volume of inactive clinics that we noticed that day, and that took a long time to go through and verify that they were definitely closed, that they were definitely gone. But in the end, it was a very positive thing, because when you started, we were starting with the right opening stock in terms of our outpatient clinic. So if you have your hospital and your IPIMS, you put your OCG onto it, you basically have a classified national outpatient data set. How that works is that you start with your hospital requires an outpatient clinic, or you want to register your existing outpatient clinics. Your PAS or your IPIMS clinic setup, the field required is the OCG. It has to be on it. You come on to the HPO's clinic registration, you fill in the form, you're consistent with classification, and the OCG is agreed between the HPO and the hospital. You then put that OCG in your IPIMS clinic setup window. It then sits on your hospital IPMS or your PAS database. It's there. No coding needs to be done, no charts need to be pulled. It is sitting there as a central point in your database. So every patient attending an outpatient appointment is assigned the OCG based on the clinic that they attend. It's there at the source, it's there at the point of contact. So say if I, Lorna Collins, am attending Ennis outpatient and I'm attending the respiratory clinic and I'm seeing Dr. Deirdre Murphy. Sorry, you're in front of me, so you keep getting picked on. But we know Dr. Deirdre Murphy has a PAS clinic code DM12345. We know, because Deirdre's clinic has been registered, that it has a OCG of 20,190, which is the respiratory medical consultation clinic. So when I rock up to outpatients and say, I'm here for my appointment because I can't breathe most of the time and here's respiratory, as soon as I check in, I'm checking into DM12345, the OCG automatically gets added to my record because it's part of the hospital's IPIMS and PAS database. So it takes away all of that coding and charting, and it captures the clinic and the classification. So that way, if you look at it in terms of your HBO clinic register, if you have that by hospital, you have that by group, it rolls up then to your national outpatient clinic database. It gives you all of the activity and resource intensity of the clinic in terms of costing it and when it's happening. If your OCG is sitting on your hospital database, that rolls up to your group, that rolls up to your national outpatient OCG classified database in the perfect world. In terms of the activity that we were looking at, I used the OSPIP MDS from a few years ago. ASPIP is Outpatient Services Performance Improvement Programme. I think it's fallen now under scheduled care in terms of acutes. For the pilot, I identified 41 variables that I felt describe the attendance. So it's the demographics, the classification, the service, what's actually happening to the patient when they attend. That service was able to use that as our HPO minimum data set. We were consistent with the definitions that OSPIP had, so for under every variable we were consistent with the items that were within that. We then transferred that data from UL on a secure transfer because there's currently no data capture automation in place for outpatients. Part of the pilot is that we're going to have to review those variables and whether that's appropriate going forward as a national outpatient database, and also the capture and how we do that. So at a very high level, the components I've spoken about are your IPIMs and your PAS and setting up of your clinics. You want to use your outpatient classification to map your clinics to the OCG, and that's done through the outpatient clinic register. Once you have your OCG, every outpatient attendance is assigned the classification, the OCG. You then have outpatient patient level data. Once you have that data and it's classified data, you can start costing that data. You can start coming up with rule sets of how you cost it, and if you can cost it, you can try and fund it. That's the basics of what we're trying to come through. The benefits of better outpatient data: the HBO clinic register will provide extensive information on your clinic's operation and your system. It becomes your outpatient management business intelligent tool. There's a dashboard at your fingers to be able to look and see exactly what you want and when you want to do it. Better outpatient data will allow for more information decision making, particularly in relation to shift left, that move into more care from the acute system, the community-based system. You need to be able to see what you have so that you can move what's appropriate. It also allows for more effective use of services and better policy decisions, and it's evidence-based policy decisions because you actually have the information at hand. Every person that attends an outpatient appointment is consuming a resource, whether it's procedural or consult or allied health or diagnostic. There's staffing, there's rooms, there's procedures. Everything consumes a resource. At present, hospitals define their own directorates. Specialties are not a clinical classification, and therefore the comparability of outpatients across the system is extremely difficult. To be able to fund a system, it's necessary to identify the activity, to classify the activity, and identify the costs of that activity, so that ultimately you can allocate the appropriate funding to potentially incentivise the moving activity from day case to outpatient to community. So where are we now? I'm using COVID as an excuse. I know we're not supposed to, but it really took such a toll, particularly on developmental projects, because they just weren't a priority. Every person I spoke to in UL was being pulled and reallocated to different areas, but it did have a major impact on our outpatient project. Despite this, we've tried to continue the work of the OCG, so we've tried to continue the work of the classification, we've tried to keep up to date with the Australian system. We've also continued to develop our online clinic register so that when things were ready to go, we were ready to go. I think the work we've done in the UL group provides a very strong basis for progressing this project into 2022. And the plan now is to have a working group, and the aim of convening the group is to put the structure in place to ensure that the project can recommence with sufficient backing in key areas. So if you wanted to, say, be involved in an outpatient pilot project, this is what it would kind of look like. It's your roadmap. So we'd continue to develop the outpatient classification based on what we see through in the pilots. Is there outpatient clinics that we haven't taken into account that happen in Ireland but don't necessarily happen in Australia? We'd complete our UL pilot and we'd refresh the classification to make sure we have all of the outpatient clinics that have happened in the intervening time. We would then implement the classification in further pilot sites, if anybody wanted to be a pilot site, and we try and get a representative sample for the pilot. We then need to develop the minimum data set for outpatients and the associated data collection, and then we need to implement that in further sites, pilot sites. We need to further develop the outpatient costing to reflect the different clinic types, and then for the pilot, develop a set of price weights for outpatients and ABF funding and try and do that shadow funding that Jerry mentioned. So thank you very much for your time. I think coffee should be ready soon. But if anybody wants any kind of information on outpatients or they want to have a demonstration, then send me an email and I'll be very happy to go through it with you all. Okay.